how the graph turns heart's electrical activity into a readable lines. Assess whether the cardiac rhythm is in synchrony and whether there is any cardiac arrhythmias that is happening. 12 leads, the V1 to V6, lead 1, lead 2, lead 3, AVR, AVL and AVF. This table depicts what each lead represents. Understanding the electrical axis is helpful in understanding certain type of problems like bundle branch blocks or hypertrophies. The atrial fibrillation, the SVT and the ventricular tachycardia. There is a natural delay that happens at the AV node which is altered in this disease. If there is a problem in the His-Purkinje system, there could be block in either the right bundle or a left bundle, leading to delayed contraction of that part of the heart. Looking at the ECG and picking up acute myocardial infarction is something which every MBBS student should be able to do. There are so many other criteria also which describe the LVH and RVH, but remembering this is sufficient to help you pass your examination. Namaste. Welcome to Tanu, the amazing story of you told from the inside. Every heartbeat, every breath and every cell in your body has a story to tell. We at Tanu convert those stories into amazing ideas that you can see, feel, comprehend and understand. It's not about biology, it's about wonder, it's about curiosity. So whether you're a student, parent, patient or somebody who's just curious to learn, this is the space to explore human body one story at a time. With Tanuvu, discover the marvels within. ECG is often a point of fun for the examiners and nightmare for the students. It's an ancillary topic, it doesn't come under the main topics of medicine. So it has to be studied thoroughly and effectively to understand and clear the viva with flying colors. So let's dive deeper into it. Step 1 is to understand the mystics of ECG graph. How the graph turns heart's electrical activity into a readable lines. ECG graph has tiny boxes called the atoms. Each atom represents 0.04 seconds in the horizontal plane and 0.1 millivolts in the vertical plane. 5 of these boxes together form what is called a brick, which represents 0.2 seconds. This happens because the ECG runs at a speed of 25 millimeters per second. Now, if you do not know the speed of the ECG graph, you will not know whether the heart is racing or sleeping. So, 3 aspects to remember here. Atom is 0.04 seconds in the horizontal plane, 0.1 millivolt in the vertical plane. 5 of the atoms together form a brick which is 0.2 seconds. And the ECG paper runs at a speed of 25 millimeters per second. Step 2 in reading ECG is to understand the waveforms, the P, the QRS complex and the T waves. So why each wave dip represents conduction, injury or recovery of the muscle. So let's dive deeper into this. The P wave represents atrial depolarization. Depolarization can be taken as a contraction of the atrial muscle. The QRS complex represents ventricular depolarization, whereas the T wave represents ventricular recovery or the repolarization. Now there is also atrial repolarization which happens, but it is hidden in the QRS complex, and because of the massive electrical voltage, it is not visible on the ECG. The PR interval is a crucial aspect to understand. The normal PR interval is 0.12 to 0.20 seconds. That is 3 to 5 small boxes. This represents the delay that happens at the AV node before the impulse is conducted into the ventricles to facilitate a synchronous contraction between atria and the ventricles. The QRS complex is usually narrow, represented by 0.12 seconds, which comes to 3 small boxes. The last is the QT interval, which represents the ventricular cycle of the contraction of heart. It is 0.36 to 0.44 seconds, that is somewhere between 9 to 11 small squares. So understanding these values help us to assess whether the cardiac rhythm is in synchrony and whether there is any cardiac arrhythmias that is happening. So 3 important aspects to remember here. The PR interval 0.12 to 0.20 seconds or 3 to 5 small boxes. The QRS complex 3 small boxes or 0.12 seconds, and the QT interval which is 0.36 to 0.44, that is 9 to 11 small boxes. Step 3. Step 3 involves understanding the cardiac leads. Cardiac leads can be considered as camera crew recording the cardiac cycle from different angles. There are 12 leads, the V1 to V6, lead 1, lead 2, lead 3, AVR, AVL and AVF. The chest leads or the transverse leads record the cardiac cycle from anterior to the left lateral side. They are V1 to V6 as depicted in the image. This is easy to understand as we move on the chest leads. The limb leads become a little more complex. There are 3 simple leads which are AVR, which records the cardiac cycle from the right arm, AVL, which records the cardiac cycle from the left arm, and AVF, which records the cardiac cycle from the foot. So it is as if the camera is pointing at the heart from below, from the right arm or the left arm, and looking at the voltage complexes which are coming towards the camera. Now lead 1, lead 2 and lead 3 become a little more complex. Lead 1 indicates or studies the vectors of current which are moving from the right arm to the left arm. That is the vector of the current which is flowing in this direction. Whereas lead 2 records the electrical current vectors which are moving from the right arm to the foot, and lead 3 represent the electrical vectors which are moving from the left arm to the foot. Understanding all these leads gives us an idea of what is happening in which part of the heart. Now this has become a little complex. If you are not able to remember everything of this, it is still okay if you remember 3 take-home messages from this. The cardiac leads that represent the inferior wall or which look at the inferior aspect of the heart are lead 2, lead 3 and AVF. The leads which record the lateral aspect of the heart are lead 1, AVL, V5 and V6. The leads which look at the anterior aspect of the heart are V1 to V4. Now this table depicts what each lead represents, and it is enough for you to remember this to understand the changes which are happening in these areas. If you want to understand a little more deeper, you have to know the coronaries which supply these areas. Again, for each of these representations, there are 3 separate coronaries. The inferior wall of the heart is predominantly supplied by the right coronary artery. So any changes that you see in these areas are due to problem in the right coronary. The anterior aspect of the heart is supplied by left anterior descending, and any changes that you see in these areas are a problem in the left anterior descending artery. The left circumflex supplies left lateral aspect of the heart, which is predominantly the left ventricle. So any changes happening there indicate a problem of the left circumflex artery. Now the left main divides into left anterior descending and left circumflex. The left main is notoriously called the widower's artery because blocking of the left main makes the survival of the patient extremely difficult. So understanding 3 coronaries, 3 areas which are supplied by those vessels, and the leads which represent these areas in sequence helps you to read ECG, particularly when you are understanding about the coronary ischemia or myocardial infarctions. Step 4 in reading ECG. Step 4 in reading ECG is to understand the electrical axis of the heart. It can be called as the true north for the heart. Now, electrical axis, though there are different currents flowing in the heart in different directions, the major electrical impulse comes from the left ventricle, where the electricity flows towards the left and lower aspect of the chest, which can be considered as the main vector in the ECG, which is represented by the QRS complex. Understanding the electrical axis is helpful in understanding certain type of problems like bundle branch blocks or hypertrophies. The simple way of reading the axis of the heart is by simply looking at 2 leads, lead 1 and AVF. Say lead 1 is represented by your left thumb and AVF is represented by your right thumb. If both are upright, then the axis is normal. But if the AVF is inverted, that is, the leads seem to be moving away from each other, that is, they are leaving each other, it is left axis deviation. Whereas if AVF is upright but lead 1 is inverted, the leads seem to be reaching for each other. The QRS complexes in these leads seem to be reaching for each other, then it is a right axis deviation. So just simply looking at the leads 1 and AVF, you can understand whether the axis is normal or deviated. So the conclusion is a simple rule of thumb, literally, which is if both leads are upright, then it is a normal axis. If the leads are reaching for each other, it is a right axis deviation. If the leads are leaving from each other, it is a left axis deviation. Step 5 in reading ECG is to master the tachycardia algorithm. There are a lot of tachycardias. I will not be going into in-depth of everything. The idea of this is to master the 3 main tachycardias that are commonly seen on ECGs. The atrial fibrillation, the SVT and the ventricular tachycardia. Let's dive deep in. The atrial fibrillation is because of the impulse which is originating somewhere in the atria but not in the SA node. So the P waves are absent, the QRS complex are narrow but they are irregular. So it's a tachycardia with irregular cardiac rhythm and P waves absent. The SVT is the origin of the impulse somewhere in the AV node. So the rhythm is regular, there is tachycardia and the complexes are narrow. The third one is the VT. Here the origin of the impulse seems somewhere in the left ventricle or the right ventricle. Hence there is a broad QRS complex because the conduction of the impulse is through the ventricles but not the standard His-Purkinje system. This leads to broad complex tachycardia with poor visibility of any other wave. This is most of the times fatal and is a medical emergency. So 3 main tachyarrhythmias that a student should not miss: the atrial fibrillation, the SVT and the VT. Step 6 in understanding the ECG is to know about the AV blocks. It is a problem in the PR interval, that is the conduction of the impulse from atria into the ventricles. There is a natural delay that happens at the AV node which is altered in this disease. This conduction of impulse can be altered in 4 different ways. Type 1, type 2 which includes 2 types and then type 3. So let's understand each one of them. In type 1 AV block, there is a simple delay in the conduction of impulse from atria to the ventricles, but every time there is a definite conduction through the AV node. So it is simple prolongation of the PR interval. Type 2 AV block is a phenomena where there is sometimes a missed conduction. That means sometimes there is a P but there is not a following QRS complex. This can happen in 2 ways. One is longer gone phenomenon. This is also called Venki-back phenomenon. Here the atrial impulse is conducted to the ventricles but then there is a prolongation of the conduction of impulse over the next 2 or 3 successive beats and then suddenly there is a drop. Whereas Mobitz type 2, which is also called type 2B block, is a phenomenon where there is suddenly a dropped beat. That means suddenly there is no conduction of impulse from the atria. There is a P wave, it is not followed by a QRS complex. It can be called as a fine drop phenomenon. The third degree AV block is AV dissociation. That means atria conduct at their own rate and pace and the ventricles are conducting at their own rate and pace. It can be called as no talk, 2 clocks. So this 4 complete the common AV block abnormalities. So to conclude, there are 4 ways in which the impulse from atria can be alteredly conducted into the ventricles. Type 1, prolongation of PR interval which is late but not lost. Type 2A which is called Venki-back phenomenon which is longer gone. Type 2B or also called the Mobitz block is when it is a fine drop phenomenon. That means there is a fine conduction of impulses and then there is a sudden drop. Type 3 block, which can be also called as no talk, 2 clocks. That is, the atria and ventricles beat at their own pace. Looking at these ECGs, you can get an understanding of each of these phenomena, how these impulses are conducted or not conducted. Step 7 in reading ECG is understanding the bundle branch blocks, the ventricular asynchrony, a house that is divided. Let's dive deep in. The impulse after the AV node transfers into the ventricles through his Purkinje system. This is meant to conduct the electrical impulse at a rapid rate, leading to synchronous and effective contraction of the ventricle. Now, if there is a problem in the his Purkinje system, there could be block in either the right bundle or a left bundle, leading to delayed contraction of that part of the heart. So let's understand how these phenomena are looked at by our camera crew. The bundle branch blocks, how do they happen? Why does ECG shows specific changes are a part of discussion somewhere else? Our idea is only to remember and understand the main changes which can be picked up in ECGs in these bundle branch blocks. It can be a left bundle branch block or a right bundle branch block. You have to look at only at the transverse plane. You need to look at only two leads, V1 and V6. So what happens in right bundle branch block is that you see what is a phenomenon called marrow. The V1 shows an M pattern as can be visualized here. The V6 shows a W pattern. If you see this pattern, it is likely that the patient has a right bundle branch block. Now, the left bundle branch block can be remembered by a pattern called William. There is a W pattern in V1 and then there is an M pattern in the V6. Simply looking at V1 and V6 and identifying these patterns can help you pick up the bundle branch blocks. So concluding, the marrow for the right bundle branch block, the M and W, whereas the William for the left bundle branch block, which is W and M in V1 and V6 leads. This can help you easily pick up the bundle branch blocks. Step 8 in reading ECG is to understand the ischemic changes or the acute myocardial infarction. It is a medical emergency, and looking at the ECG and picking up acute myocardial infarction is something which every MBBS student should be able to do. So let's dive deep into the ischemia of the heart. ST and T waves. These are the primary areas which you should look at when you are looking for ischemia. The ST segment is actually an isoelectric line. That means there is no electrical impulse that is being conducted when during the ST segment time. But if there is an ischemia of the heart muscle or if there is an infarction, the resting membrane potential, which is normally minus 90, is a little positive towards say minus 60. This leads to movement of current even when there is an isoelectric line, leading to deviation of the ST segment from the baseline either up or down. Now when it moves up, it means that there is a transmural infarction. When it moves down, it means that there is a subendocardial ischemia. This is because the electrical vector moves in or out depending upon the state of the muscle, whether the muscle is completely necrosed or whether the muscle is simply ischemic. Now with this understanding, let's move in further to know which leads are damaged to which part of the muscle. This we have already learned in step 3, where we have studied about how the camera crew look at different parts of the heart. The T wave is the other segment which shows changes in the ischemia infarction. During the state of acute infarction, there is a tall symmetrical fat T wave, whereas during ischemia there is a inverted T wave. But the changes of the ST segment are the primary ones which pick up an acute myocardial infarction. Now, if you look at the inferior leads, if there is an acute MI, there is a ST segment elevation in these leads. Now, as we discussed before, it's the same cardiac cycle which is being recorded by different camera. In the case of inferior wall infarction, the inferior leads see that the ST segment is elevated. The reciprocal changes happen in the leads which are directed towards the left lateral side, which show ST segment depression. Now looking at the reciprocal leads, that is 2,3 AVF showing ST segment elevation and lead 1 AVL showing the ST segment depression, you can confirm that it is a myocardial infarction. Now, the reason why it is important to look at the reciprocal changes is sometimes there are phenomena called benign early repolarization and pericarditis, which can cause a diffuse ST segment elevations. So mere ST segment elevation is not enough to diagnose MI if you are able to show that there are reciprocal changes. Say for example, if there is an acute MI in the left lateral wall, the left lateral wall shows ST segment elevation and the inferior leads show ST segment depression. Anterior wall MI also shows reciprocal changes, but we do not commonly connect the leads in the back. But if you connect the leads, there are some textbooks that suggest that you should connect the leads posteriorly called V7 and V8 to look at the reciprocal changes for the anterior wall. So the take home message of this is acute MI, STT changes, ST segment elevation in case of infarction, depression in case of ischemia, hyperacute T waves followed by T wave inversions which reflect the ischemic changes with respect to T wave. The reciprocal changes, 2-3 AVF reciprocal changes are seen in lead 1 and AVL. The anterior wall MI reciprocal changes are not commonly read in the standard ECG, but if you want to pick it up, you can use the V7, V8 leads. So that concludes myocardial infarction. Step 9 is to understand the ventricular hypertrophy. You have come a long way in reading ECG, starting from the basics to the AV blocks, to the tachyarrhythmias and myocardial infarction. So the next step is to understand when the heart is bodybuilder and is electrically and mechanically overloaded. So let's understand the changes that are seen in this. How the hypertrophy happens, how the ECG and why the ECG shows these changes is not a discussion for today. That is a point of discussion somewhere else. We'll simply understand the rules to identify RVH and LVH. If the S wave in V1 plus R wave in V6 is more than 35, it means that the left ventricular hypertrophy is not. SV1 plus RV6 is more than 35. This is called the Sokolov criteria. However, if the R wave in V5 is longer than V6, you can use that. So it is either V5 or V6. If the total is more than 35, it means that there is a left ventricular hypertrophy. When it comes to right ventricle, it is much more simple. If the R wave in V1 is positive, it means that there is a right ventricular hypertrophy. There are so many other criteria also which describe the LVH and RVH, but remembering this is sufficient to help you pass your examination and pick up the most common problems with respect to hypertrophy. So SV1 plus RV6 or V5 more than 35 for LVH and positive R wave in V1 for RVH are the criteria for ventricular hypertrophies. Congratulations if you have reached the step 10. That means you have understood a lot of things about ECG. Step 10 is a simple error that you need to pick up whenever you look at ECG. So it's called the mirror world. As we discussed, the AVR is the lead which is looking at the heart from the right arm. So all the waves in AVR are supposedly negative because most of the impulses traveling from the SA node to the AV node and then all over the ventricle are the vector is predominantly directed down and out, whereas AVR is looking exactly in the opposite direction. However, there are some situations where AVR is positive. So first, when you look at ECG, look at AVR. If it is positive, that means there is something wrong. The most common reason why this is wrong is the technician has wrongly connected the right lead towards the left and left towards the right. So picking this up is very important. The only other situation where this phenomenon can occur is there is a dextrocardia. This is quite uncommon, but if you pick it up, you're one in thousands of those doctors who have identified this situation in your patient. So that concludes the ECG. I hope it has been a useful session for the residents. Going through from step 1 to step 10 in a systematic way helps you pick up most of the common abnormalities in ECG and clear through your exams successfully. So with Tanvu, discover the marvels.